The aim in treatment of myeloma is to really minimize the disease to the smallest level possible. You really want to eradicate it if you can. But more importantly, we want to get the patient's disease down to a level where their quality of life is good. We know that the best quality of life for myeloma patients is when their disease is suppressed. So the aim of treatment is to improve quality of life and to get them into a position where they can start to enjoy the things that they used to do. Most patients who present with myeloma do need treatment right from the start. If they have bone problems, if their kidneys are struggling a little bit because of the disease, if they're a little bit anemic or are under their weather. So most patients do need treatment. So if there's any suggestion the myeloma is causing problems in the bones, in the kidneys, in the bone marrow, we're looking for those problems, and if we find them, those patients need treatment. The good thing about myeloma is the treatment is improving, and we're using bigger combinations of drugs. The problem with combinations of drugs is they bring with them a mixture of side effects. So we're always aware of what side effects the patient might experience. So if someone has had a thrombosis in the past, we're very aware that some of our new drugs can cause thrombosis again. So those patients might need some heparin treatment, for instance. Some patients with diabetes have some problems with steroids. Their sugars become less easy to control. So with the patient in front of me, I look at the drugs and the combination of drugs we're about to use and try and figure out right from the beginning what problem our treatment might cause that patient. Most treatments in the UK and around the world now involve combinations of drugs. Steroids are a very important drug. We still use chemotherapy. Drugs such as cyclophosphamide and melphalan still have a role to play. And in newly diagnosed patients, we also like to use so-called novel agents, the agents that have emerged over the last 2 or 3 years that really are very effective in the treatment of myeloma. Thalidomide or Revlimid or Velcade. Now, a stem cell transplant is a very powerful treatment for multiple myeloma, but it's not for everyone. It's harder for patients who are older and who have other medical problems to tolerate. So one of the decisions we start to think about when a patient first presents is this patient going to be a transplant candidate? Now, sometimes a patient can be quite poorly when they present and you think they aren't a great transplant candidate, and you revise that opinion as they get better through their treatment. So age is the starting point for making that decision, but it's not an age-restricted treatment. It depends on how fit the patient is, what other medical problems there are. So we can transplant very fit 70-year-olds, but we can think that a 59-year-old with a lot of other medical problems is not fit for transplant. So it's a decision which you like to think about from the start, but it's not one I like to make until we see how the patients are doing with treatment too. So maintenance, to try and keep the disease under control for longer, is a very attractive thing for us to try and use. Our great problem is that when patients' disease is suppressed, that is a time when they have the best quality of life. So one thing we don't want to do with maintenance treatment is impact on that quality of life. We want to use drugs that are safe, that are targeted to their disease and don't bring about more in the way of side effects. So there is a role for maintenance. We know maintenance strategies often prolong the time the patient has without treatment. Well, we can measure the response to treatment in a number of ways. The protein that the tumour cell produces is a very important marker, and we want to measure that in the blood and see that that goes down to a very low level. We're also watching the patient in a whole lot of other ways. We want to make sure the kidneys are better, that their bones are improving, that their bone marrow is working in a fashion that helps them live a normal life. But relapse is always a very difficult time for the patient. it's always difficult to know in each individual patient how to treat that relapse unless you have all of their history ahead of you. So often if patients have done fantastically well with their initial treatment, you might want to go back to their initial treatment and use it again, and that's a perfectly reasonable thing to do. However, if patients have relapsed quite quickly, we tend to want to use different strategies because, like bacteria with antibiotics, the tumour cells can become resistant to our drugs. So we like to ring the changes and use different regimes to try and keep the myeloma under control and get it back into a remission. So it's often the case that what patients have at presentation, what they might have at their first relapse, and what they have at the second relapse can be different, and it can be the same. It depends, and treatment of relapse is again a very individual decision. Myeloma can present in a number of different ways, and looking after the patient is all about a holistic and team-based approach. The most important thing we do for myeloma patients, apart from treat the disease, is to look after the patient's bones. And we know that drugs called bisphosphonates, usually zoledronate or pamidronate or clodronate, are very, very powerful agents that prevent the myeloma from damaging the bones further. So when a myeloma patient presents, we like to get them on bisphosphonate therapy, and the evidence is that if you can keep them on bisphosphonate therapy for as long as possible, then you will keep their bones as healthy as possible. Patients with myeloma often have had problems with their back. They may have had collapse of their vertebrae, and sometimes they get a lot of pain from those areas, which doesn't always go away with chemotherapy and treatment. So we may ask our radiotherapy colleagues to do specific radiotherapy for very specific areas that are causing them problems. There are also other techniques to help with back pain, such as vertebroplasty and kyphoplasty, which are techniques which help support the back if it's been damaged by the myelomatous disease. Pain. Most myeloma doctors are very good at prescribing painkillers, but occasionally if the patient has a complex pain or a pain that is very difficult to treat, we always want to involve our pain colleagues. The treatment for myeloma has undergone radical changes in the last decade, and we have seen probably greater improvements in the treatment of multiple myeloma than in many other cancers. But we mustn't rest on our laurels, and I think the very exciting thing about myeloma in the future is there's still a lot of improvements that can be made and look like they are being made. We need to work out what is the best set of drugs to use for the patients, what is the best combination. Are 4 drugs better than 3 drugs in the initial treatment of the disease? Can we think about replacing stem cell transplant with treatments which are a bit more gentle for patients? Can we achieve all of the progress we've made in older patients that we've made in younger patients? And can we help our older, frailer patients achieve as good a quality of life as our younger patients? Can we suppress the disease to a level with maintenance that means that it won't come back? Can we find safer drugs to do the same job? There's a lot of work still to be done, but I think what's exciting is there are a lot of drugs coming along. We've had a great increase in the number of drugs we can use to treat myeloma, but the great thing is there seems to be more in the pipeline. So the future's exciting.